Dr. Regueiro is going to present. We're so honored and privileged to have Dr. Regueiro from the Cleveland Clinic presenting and being here as part of IBD Horizons. Thank you for joining us. Thank you.
Well, thank you, Anita, and thank you to the organizers for such a wonderful conference. I actually had not really prepared any rebuttal to Scott, despite his long diatribe. But as I was up here thinking about side effects to cannabis and the ultimate paranoia that comes with long-term cannabis use, I have noticed an increased sense of paranoia with Scott over time, and I'll just let you fill in the rest. Here are my disclosures. So, we can't get through probably a conference on IBD without showing this slide. And although this was set up for Crohn's, I would also argue that ulcerative colitis is a destructive process over time. And the idea is that probably starting earlier treatment will alter the natural course of not only Crohn's, but ulcerative colitis. So as we think about positioning our therapies and we look at the AGA pathways for ulcerative colitis, really ulcerative colitis risk comes in two categories or two flavors. Low risk is on the left, high risk is on the right. And this is high risk for colectomy. And you've seen this in your practice. The young patient presenting with fulminant disease, deep ulcers, extensive, they're in the hospital, they're on steroids. That's the patient that probably also would benefit from early intervention. When you look at the overall risks, and I put percentages around this, and it's not meant to go through this entire slide, for ulcerative colitis, about 50% of patients are on the left-hand side. They do just fine with mesalamine. They don't need more aggressive treatment. They're that lower risk group. But it's the other 50% that we're seeing possibly with an increased rate more recently, that are presenting more severe and really require ultimately biologics, and I would argue even higher rates of colectomy. Well, Brian mentioned this already, and there are data in our ulcerative colitis patients that the best treatment still is combination, and as you see from the study here with azathioprine and infliximab, was better than infliximab alone or azathioprine. So I do use combination with with infliximab as I do with adalimumab. And then the Varsity study looked at the first comparative effective head-to-head biologic study. I will tell you that there are 9 additional comparative effective studies in the pipeline, so this has now become the new norm. But this is blue is adalimumab, orange is vedolizumab, and for the primary endpoint, clinical remission, vedolizumab was statistically superior to adalimumab, as well as for endoscopic improvement. Interestingly, and this was an ARS question, there was no difference between corticosteroid-free remission, and we can discuss maybe the methodology of the study on the panel as to why maybe that is. Well, one of my jobs was to present some of the comparative effective data beyond the Varsity study, and this is actually an interesting network meta-analysis, and Sid Singh and group has done a number of these. And in red, I put careful when we apply this to clinical practice. So these are basically meta-analysis from large studies. It's the best we have. And without reading through all the kind of words on the left, the bottom line is that the effect size was positive for all treatments. So infliximab, adalimumab, golimumab, vedolizumab, tofacitinib compared to control, with the strongest signal, at least in this network meta-analysis, for primary treatment with infliximab and vedolizumab, but all of them were statistically better than placebo. Let's switch to Crohn's disease. So I mentioned the 2 flavors with ulcerative colitis, low risk and high risk. The same applies for Crohn's disease, except the high risk patient for Crohn's disease is again that younger patient, multiple segments involved, but here we get into anal, rectal, and perianal disease and fistula. I will tell you that probably the highest risk factor, the most concerning risk factor that I've seen in these patients are those that present with destructive anal rectal disease from the start. These are very difficult to control, and often not only do they need surgery, they need an ostomy, and they often will do quite well, but that's a difficult discussion to have with some of these younger patients. When we look at the overall stratification based on the AGA pathways, you'll notice a difference here as far as the percentages. Probably only less than 20% of our patients have that milder, lower risk group that does not require biologic therapies. Now, in fairness, probably in this audience, many of you practice in a community setting, you are seeing these patients, and these are patients who don't necessarily need biologic therapy, and maybe budesonide alone is an effective therapy. However, 80% of the patients do fall into that higher risk group, which will require more aggressive or what we would consider biologically active therapy. So again, looking at systematic reviews for Crohn's disease as long as first-line therapy, and this is looking at infliximab, adalimumab, certolizumab, vedolizumab, and ustekinumab, the effect of therapy was positive for all treatments except for Crohn's disease in this group, with the strongest two based on this network meta-analysis as first-line therapy for Crohn's being infliximab and adalimumab, but all again did show a benefit aside from certolizumab. What about second-line therapy in Crohn's beyond infliximab? So infliximab is first line, then we look to the second line. And in this study, it was interesting that there was an effect that was positive for second-line adalimumab and second-line ustekinumab, which was stronger than vedolizumab. And again, obviously, tofacitinib was not evaluated. So at least in terms of second-line behind infliximab based on the network meta-analysis, there was a benefit of adalimumab and ustekinumab. Combination, again, you've seen this a million times. We do see the benefit of combination therapy based on the SONIC study with Crohn's disease, which I think is pretty clear. So how do we monitor IBD? And this is actually was published a couple of years ago in Gastro, and this is essentially how I practice. Focus more on the green on the right-hand side. For that high-risk patient, we want to see some not only clinical improvement, but objective biomarker improvement by 3 to 4 months. If there is improvement, then it's 6 months, usually after starting a biologic therapy. I'm doing a colonoscopy and or cross-sectional imaging. Now, I will say for the patient who's really achieved remission, normal CRP and fecal calprotectin, I may actually wait a year before I do that cross-sectional imaging and colonoscopy. Well, I'm going to just end with my safety positioning, and then I'll give you my overall approach based in my practice, how I look at this. We've talked a lot about safety today. Obviously, prevention is the best in terms of avoiding complication. We talked about vaccination, checklists, and those types of things. One thing I think we need to look at in terms of safety, if there is an adverse event that occurs, we need to ask ourselves, is this related to the IBD or is this related to the medicine? So a classic example that Anita presented earlier is psoriasis in anti-TNF. Yes, there's a relationship. If it's PSC in an anti-TNF, the answer is no. And while that sounds simple, I think we have to be careful not to assign safety to something that's not related to the medicine. Anti-TNFs, our biggest safety signal are infections, and we've seen this time and time again. With the JAK inhibitors, we already discussed this. And then anti-IL-12, 23, and vedolizumab, at least at this point, both are actually probably considered as monotherapy, the safest two medicines we have as far as IBD. And then age does matter. So why does Anita present and purposely say 65? Over the age of 60, we're using more monotherapy than combination, although we should not withhold our best treatment if we think that that's going to be the most effective. So Ben Click, one of my colleagues that had been at Pittsburgh and now is with me in Cleveland, we published the safety pyramid, which you've seen. This is not evidence-based. This is just more of our approach to overall safety. And you can see kind of the pyramid with the safest being on top, monotherapy, vedo, and ustekinumab. Steroids are still the least safe. I think we all have seen that. And also important is that inadequate treatment should be considered a safety event. So having a patient with smoldering UC for years or active recurrent Crohn's disease, that into itself, in my estimation, is an unsafe event. So how do we position biologics? I took this from Corey Siegel, and I think there are many factors that go into this, including our payers, our insurance company, in terms of what are the agents we're eligible and able to use. But managing expectations for the patient are also important. So this is my last slide, and I'll just go through kind of how I practice. So first of all, an FDA note, and you've heard this already, in terms of tofacitinib right now, we're using beyond second to anti-TNF. And I do think insurance companies are still approving anti-TNF as the first-line agent. Well, for your severe ulcerative colitic patient, especially that one that's either about to be in the hospital or contemplating hospitalization, in Anita's case, I would still use infliximab with azathioprine. That's my first go-to for severe UC. If tofa has the ability to become a first-line agent, I would consider that. If infliximab fails, the patient's not ready for colectomy, which is sometimes the best option, then I would use tofa as second line. So this is the severe UC. Less severe outpatient, moderate, over the age of 60, I would use Vito or ustekinumab as first-line monotherapy. If they're under 60, I would still use Vito or ustekinumab as my first-line monotherapy. If they've failed that or looking at second line, I'm more apt to go to tofacitinib or an anti-TNF immunomodulator if they're becoming more severe. What about Crohn's disease? If it's Crohn's disease in one segment without fistula, over 60, again, Vito or ustekinumab monotherapy. However, if they have extensive Crohn's disease or severe fistula, I look at that as severe UC, and I would still use infliximab with an immunomodulator for that group. So you can see the very severe, I'm still leaning toward infliximab with an immunomodulator. Less severe, more monotherapy, Vito or ustekinumab. If they've lost response to an anti-TNF, if that is the first anti-TNF, and if it's a secondary loss of response, especially if they've been on subcutaneous anti-TNF and they've done well and lost response, I think switching to infliximab is completely reasonable, but then you get into ustekinumab and tofacitinib are reasonable. Vito after an anti-TNF failure may not be looking as good as we think. It's not to say you can't do that, and many insurance companies will approve Vito second line, but that's something where I pause. If they've lost response to infliximab, I don't go to a secondary subcutaneous anti-TNF. That's been a change in my practice over time. So losing response to infliximab, I'm more likely to go to tofa or ustekinumab in that patient, more even so than vedolizumab. If it's a primary loss of response, they just haven't responded to the anti-TNF at all, then I switch out of class. And for UC, I'm more likely to use tofacitinib or ustekinumab over Vito. Extraintestinal, we've talked about this already. If it's secondary to bowel inflammation, it doesn't matter what you use. Any of them are fine. If it's pyoderma, uveitis, central arthritis, I will still use anti-TNF, more in combination with methotrexate, but I think ustekinumab and tofa are reasonable. And then finally, pregnancy. Any of the mAbs, any of the monoclonal antibodies are fine. Something that's changed in my practice, I don't stop them in the third trimester. I treat through. I think we've seen too many women flare right at the delivery or after and develop immunogenicity. I continue through. I tell them to tell the pediatrician rotavirus live vaccine in their baby at 2 months probably is something we would hold. But otherwise, I would treat through. I avoid tofacitinib. It has a rapid clearance. I want them off at least a month. Methotrexate at least 3 months off before considering pregnancy. So with that, that's how I practice. I appreciate your attention, and thank you very much for your questions that will come.